Okay. I'm sharing my screen, so you should be seeing the questions that are projected here. A nurse is providing teaching to a client who has coronary artery disease. Which of the following statements should the nurse include in the teaching to explain the correlation between changes in the coronary arteries and manifestations that occur? The options are the coronary arteries decrease in diameter, leading to insufficient blood oxygen and nutrients reaching to the heart muscle. Okay, I like it. Sorry, just a moment. Let's see the other one because we cannot choose the first one without seeing the other ones. Coronary arteries become more elastic. It is wrong. It is wrong. Okay, the process of coronary artery disease is associated with aging, and in the process of aging, elasticity is lost, is not gained. So it doesn't make sense. Sorry again. Uh, causing the arteries to stretch as individuals age, causing the heart not to receive enough oxygen. So even if they mention that it's related with aging, and they mention correctly that the heart is not receiving enough oxygen, the statement that the arteries become more elastic, more compliant, is incorrect. So we discard this option. The heart in the coronary arteries weaken, leading to poor perfusion and resulting in angina. Okay, it could be confusing, but it's not the heart, okay, the one that become weak. The process is the coronary arteries become narrower because the growth of the plaque of atheroma, atherosclerosis. This can be silent for many years, decades, and the heart is still not suffering any consequence of that. With the pass of the time, then the heart can become weak if the heart suffers a myocardial infarction. So this statement is not better than the first one. The statement the heart and the coronary arteries becomes weak is not true because weakness translate you know that the capacity of contraction of the cardiac muscle, I mean the myocardium, is decreased, and this is not the problem in coronary artery disease. In coronary artery disease is just a narrowing of the pipe that transport blood and oxygen. It's not weakening of the myocardium. So it doesn't look correct. Notice how they try to confuse us because it's true that there is poor perfusion and angina, but it's not consequence of weakening of
¿Cuánto
the
vaya, mira?
muscle.
Para no te tormentes esto.
Eh, if there is not a question, mute your microphone. And the last one say coronary arteries decrease in diameter. Yes. Well, decreasing diameter is not properly decreasing in diameter. They don't decrease. But let's continue reading. Leading to insufficient blood, oxygen, and nutrients reaching the heart muscle is the same as the first. Manifestation occurs due to dilation of coronary arteries. No, this is statement. Look how they try to confuse us. You need to learn how to survive on test banks. Test banks are, private, for profit. Okay, all of them. Um, um, Systems that overtrain us for anchors. They prepare us for anchors. But I need to say what I always say and what I think, and this has been, verified by everybody and by the own anchors. Anchors is straightforward. They don't say those nonsenses. Okay. Manifestations occurs to dilation. No, there is no dilation of coronary arteries. By the contrary, there is narrowing. So there is a contradiction here. If they say decrease in diameter, you cannot talk at the same time of dilation because this is a contradiction. So this option that sounds very coronary arteries decrease in diameter, leading to insufficient oxygen, blood oxygen, and nutrients reaching to the heart muscle. Okay, is continued by a second statement that says manifestation occurs due to dilation of coronary arteries with increased blood flow. No, it's decreased blood flow causing increased pressure. So this is a nonsense option. It is a contradiction that is in this question that sounds like a typo. No, I don't know if a typo, because notice that the first sentence is the same sentence that is in option A, which is correct, but the second sentence is totally incorrect. So probably it's a mistake. No, it's a mistake. So after analyzing that, the option that fits better is coronary arteries decrease in diameter, leading to insufficient blood, oxygen, and nutrients reaching the heart muscle. Okay, so this is the best option that you can choose for this question. And if you click it, it's correct. Over time, builds up plaque builds up may become significant enough that not enough blood, oxygen, and nutrients reach the heart muscle during times of increased demand, such as exercise, and manifestations of angina occurs. Once the arteries become significantly narrowed, ischemia of the heart muscle can occur, leading to angina at rest or myocardial infarction if the artery is occluded or the plaque becomes disrupted. Okay, so here there is a lot of information that can also be tested in any moment. For example, why those plaques of cholesterol builds up inside the coronary arteries? It is important. Risk factors for atherosclerosis. Okay, and we need to know. Let me see if we can find something related. We need to know. Yes, here is okay that we have risk factors that are not modifiable and risk factors that are modifiable. Of course, the important one are the modifiable. And this is a high yield. This is a high yield for your test. The non-modifiable is aging. Of course, you cannot modify the process of aging. In relation with gender, males suffer sooner coronary artery disease or buildup of plaques than females. Why? Estrogen, while the woman is fertile, while the woman has functional ovaries and are producing estrogens, the estrogens are protective in this aspect. They slow down the process of atherosclerosis, mainly through modifications in the levels of lipoproteins in the blood. So male suffers of coronary artery disease sooner in their age than females. It doesn't mean that females don't suffer that. Yes, because females tends to live a little more, then can at the end develop the disease, but later. Females tends to suffer this disease, the usual, the common, after menopause. After menopause, females catch up with the incidence of coronary artery disease in males. And genetic is important. So if there is a strong family history of myocardial infarction, especially in younger people, it's considered younger before 60s. No, people that before they are 60s suffer of coronary artery disease or stroke. Okay, this is an important genetic influence. But modifiable are the hyperlipidemia, specifically the high cholesterol. Of the cholesterol, remember that we have two forms of cholesterol. One cholesterol associated with low density lipoprotein, LDL, that is the bad cholesterol, is the cholesterol that can deposit in the walls of the pipes of the artery that you see in this picture, producing the plaque of atheroma. While the HDL cholesterol, the high density lipoprotein cholesterol, is by the contrary protective. So having high LDL and or low HDLs are risk factors for coronary artery disease. Is considered high LDL more than 100. I don't think it's going to be tested in Nclex. It is considered low HDL less than 45. I don't think this value is going to be tested in Nclex. So if you don't want to memorize that, I wouldn't force you to memorize that. The triglycerides is another type of fats that are circulating in the blood, but the triglycerides are more related with alterations in the metabolism of the carbohydrates. Carbohydrates can transform in triglycerides. So triglycerides are especially elevated in obese and diabetics clients. Triglycerides, elevation of the triglycerides are also risk factor for this stuff. It's considered high above 150. Triglycerides can transform at the end in LDL to make it simple. That's why it's also considered a risk factor. There is a group of the diet. Okay, you need to know about the diet. Okay, they can be tested in your English about the diet. Absolutely. So there are fats. There are fats that are not healthy. Are called saturated. Saturated. Okay, it's called saturated. Saturated because the chains of fatty acids. Okay, have all their balances saturated with hydrogen, okay? The hydrogenated fats are the worst of all the fats, are also called trans fatty acid or trans fats, okay? Because are monster forms of those fats created artificially in the industry to provide better taste and longer shelf life of the product that contain those fats to prevent oxidation and becoming rancid. Okay, saturated, very bad. You need to know that saturated are mainly present in animal food, especially beef. There are animal food that is low in these bad fats. For example, fish. For example, lean poultry. You know, the poultry without the skin and the fat are accepted as good sources of proteins and fats, but the beef and the fatty component of the milk, I mean the dairy, cheeses, whole milk, butter, etc. Beef and dairy are sources of saturated fat, are not good. Vegetables have fats that are unsaturated, monounsaturated or polyunsaturated. Those are good. So if we are talking about the fats of the olive oil, the fats of the avocado, the fats of the nuts, tree nuts or peanuts, legumes, etc., are good fats. All this can be tested in English, and I can assure you that I have proof that can be tested. These are basic culture of how to recommend clients to decrease their risk, decreasing or improving the type of food that they are eating. Summarizing, more fish, more poultry, how do you call that? Fat-free, no, skim milk derivate, and a lot of vegetables, tree nuts, legumes, beans, etc., etc. Decrease beef, decrease dairy. It is important. It is tested. Okay. Of course, keeping the adequate weight in exercising, because obesity and sedentarism, okay, affects this, increases this. Apart that obesity and sedentarism also influences in other two modifiable risk factor, which is hypertension and diabetes mellitus, especially diabetes mellitus type 2. Yeah. So hypertension and diabetes mellitus are also important, modifiable risk factor for coronary artery disease. Tobacco is another modifiable that can be quit. Okay. Don't forget that in the management of the hyperlipidemia, we have the statins, and the statins are loved in your Nclex to be evaluated. Remember that statins are a wonderful medication that decrease the LDL and increase the HDL. But as anything, they have side effects. They are hepatotoxic, mildly hepatotoxic. So we need to monitor the AST, ALT, that you know are the liver function tests, AST and ALT. But the most important and the most commonly tested is that they are able, in rare occasions, not commonly, is a bad luck situation, is an idiosyncratic situation. In some situations, they can produce like this rupture. Let's not see inflammation, a disruption in the muscle cells, the skeletal muscle cells is called the myolysis or rhabdomyolysis, okay? Myolysis is a myopathy in which the muscle bursts, releasing to the circulation what is inside the muscle, which is the myoglobin. And the myoglobin is the hemoglobin, myoglobin is the hemoglobin, hemoglobin, quotation mark, okay, hemoglobin of the muscles. And this myoglobin should be inside the muscle cells, not outside. When this myoglobin is released to the circulation, it's toxic, and especially toxic for the kidneys, because then this myoglobin is spilled in the urine as a myoglobinuria and can produce acute renal failure. And remember that this serious, frequently tested complication manifests with muscle pain and muscle weakness. In Nclex is not going to tell you muscle weakness. They are going to tell you the clients complain that cannot get up from a chair, okay, without the holding in the on the walls or something like this. So you need to interpret when a person is unable to get up from a chair is because it's having muscle weakness. It's taking statins because high cholesterol, and it is important. Don't forget, because it's frequently tested, that the grapefruit juice, okay, increases the risk of toxicity of the statins. So it's a no-no to take statins with grapefruit juice, okay? Very good. What else they can? Well, hypertension, treatment, diabetes, tobacco. The other thing is well known by you. Okay, so this is important. Remember that when we have a plaque of cholesterol, when we have a plaque of cholesterol growing in some artery, the growth occurs along along years. And this accumulation of the plaque of cholesterol due to those risk factors is progressive until there is a moment in which at the beginning the blood flow is not impaired because this space that is left here is enough for the blood to circulate. But there is a moment in which the obstruction is so significant that when the client start doing exercise and the heart, the heart, that is the part of the heart that is depending on this partially obstructed coronary artery is demanding more blood, needs more blood. I need more blood because I'm exercising. I need more blood, more oxygen. I need more blood. This more blood cannot pass. Why? Because there is a narrowing. And then appears lack of oxygen in this little part of the heart that depends of this partially obstructed artery. When there is ischemia, which is the name of the lack of oxygen in this part of the body, the metabolism deviates from aerobic to anaerobic. In the anaerobic metabolism, which means metabolism burning glucose to produce ATP, metabolism in absence of enough oxygen. A venom, a toxin is produced called lactic acid locally. Locally is lactic acid produced. Lactic acid has a property that you need to know very well. Is produces a lot of pain. Lactic acid, in contact with the nerve terminal produces a lot of pain. That's why the patient experiences pain, chest pain, because the heart is in the chest. But it is a visceral pain. And you know that visceral pains are very weird. You maybe feels the pain in another part. This pain can be perceived, okay, can be perceived in the jaw, can be perceived in the neck, can be perceived either in right or left arm. Not only left arm, can be also perceived in left arm. Can be perceived in the epigastrium, like an indigestion or tummy ache. So it's very atypical. But also a part of this diffuse pressure-like pain, the client is going to be pale, sweating, very feeling very, very bad. Okay. Remember, because it's also tested in English, that a client that is female or is diabetic can be experiencing this ischemia without pain, with atypical symptoms. Diabetic clients, females, and very old clients can have angina and even myocardial infarction without pain. They feel, for example, shortness of breath. They feel, for example, extreme of fatigue, of tiredness, yes, etc., etc. Is also tested in English. So we need to have that in mind. Sometimes, of course, when the patient with the angina experiences this pain, what is going to do? Stop doing the exercise that was doing. When the client stops doing the exercise, the heart stops demanding more blood. So now the amount of blood that is required by this part of the heart is enough. Okay, it can be supplied in enough amount by the partially obstructed coronary arteries. Yeah, so that's it. I'm receiving messages from the school, and I don't see those messages. Okay, a mystery. Okay, so what happens then when the client stops doing the exercise, the pain disappears. And this is what characterizes the stable angina. Stable angina is an angina that appears with predictable exercise. When I say predictable, is that depending of the level of obstruction, maybe the pain occurs when you are walking 2 blocks. When you are blocking 2 walks, no, I don't see it by emails. When you are walking 2 walks, okay, and you can know that after walking the second block, sorry, is when the pain appears. It's predictable and appears with exercise. Of course, what they said, when the plaque starts growing more, and understand that it occurs along years, this process, then the pain can appear in with minimum exercise or even at rest. And then we call this unstable angina. The unstable angina is a pain that can appear even at rest and is very different, very difficult to differentiate from a myocardial infarction. And then those clients must be hospitalized. We know that clients with the stable angina, okay, with the stable angina, the clients with the stable angina, when the obstruction is partial and only appears pain during exercise are treated with statins to decrease or stabilize the growth of the plaques, are treated with statins, no, all the statins with statins, with platelets, platelets inhibitors, medication that inhibit the aggregation of platelet-forming clots, which is a big risk in those clients, platelets inhibitors, okay? And are treated with nitrates. And you know the nitroglycerin, nitrate, the nitroglycerin, or don't forget this, the isosorbide, dinitrate, dinitrate, okay? Please, they can change from the classical nitroglycerin to isosorbide dinitrate. It's the same, it's a nitrate. Remember that those medications are vasodilators, so they could favor the process of obstruction, partial obstruction that occurs in angina, but also dilate the veins and the rest of the arteries of the body. As a consequence of that, the blood pressure of this client is going to drop. So the main side effect of the nitrate is decreased blood pressure. That's why it's important to measure the blood pressure before administering the medication. If the systolic is below 90, it should be withhold the medication and consulted with the physician. All those details are tested. If these nitrates that are so potent vasodilators are combined with the erectile dysfunction medication, the Alfil, no, sildenafil, tadalafil, manelafil, etc., can produce double vasodilation and a severe catastrophic hypotension. All those, are frequently tested. One day, a client that is having this plaque of cholesterol can have a rupture, a rupture, okay, of one of the plaques because the plaques can break. When the plaques break, is going to stimulate the clumping, of the platelets over the disruption of the plaque. This clumping of the platelet, that's why those clients are taking platelets inhibitors because to prevent this phenomenon. When this clumping of platelets occurs, is going to also activate the coagulation cascade, and a mass, a clot of fibrin, a strong clot of fibrin is going to build along minutes or hours in this space, obstructing completely the path of blood. So now the blood cannot pass. Now the blood cannot pass. Because the blood cannot pass, this part of the myocardium that depends on this artery is going to die. When this happens, we are talking about myocardial infarction. What defines the myocardial infarction is the elevation of a substance that should be inside the cell of the heart. It is called troponin. So what is the conclusion here for test per troponin? Elevates only if there is necrosis, if there is myocardial infarction, if this is happening. Troponin does not elevate in angina because the angina, the ischemia, and the production of lactic acid and the pain is transient, is reversible. For that reason, the troponin doesn't elevate in the angina. But if the troponin elevate, is because a total obstruction has occurred and now the myocardium starts dying. This troponin doesn't elevate immediately, can elevate after 1 hour, 2 hours, 3 hours, or even 6 hours. So the time of elevation is variable, but it's not immediate after the myocardial infarction. But once the necrosis occurs, it starts sustained elevation is observed, and we see after several determination of troponins along the time that the concentration in blood of the troponin elevates when the myocardial infarction occurs. This elevation of the troponin can last 10, 14 days, okay, after the myocardial infarction. So it's lasting a lot. So that's it. In the EKG, when we have myocardial infarction, the classical EKG is not exclusive, but the classical EKG is to observe that the ST segment, this is the P, this is the Q, this is the R, this is the S. I'm going to go to the S. So now, instead the S going down, this S is going to change into an elevated ST segment, and the T wave tends to invert. So what you observe that this should be the place of the ST segment. This is the ST segment. Now the ST segment elevates, and it's called ST elevation myocardial infarction. Is the classical finding in the electrocardiogram of a complete myocardial infarction. Nevertheless, this change is immediate. So if they ask you in Nclex, which test should you do first in a client just arriving with chest pain suspected to be a myocardial infarction? And the answer is the EKG. Why? Because the EKG altered its morphology before the elevation of the troponin that takes, as I say, 2 hours, 3 hours, etc. So the diagnosis of MI can be done with a chest pain and the EKG alterations before the elevation of the troponin confirms this diagnosis. Okay. Nevertheless, sometimes there is not this characteristic in the EKG because the myocardial infarction has other characteristics. We don't need to know in detail this so much for English purposes. And it's called non-ST elevation myocardial infarction. And then, of course, the clinical presentation and the observation of the evolution of the troponin is going to be the most important uh, parameter to confirm that it is a myocardial infarction. Yeah. Um, what else, Pajin? Um, well, those are the most important aspects that come to my mind related with this question that we have there in ATI. Okay, related with what is coronary artery disease, what is the process of atherosclerosis. By the way, I hope that you are familiar with the metabolic syndrome. Metabolic syndrome is a very common condition. I could say that it's an epidemic. Okay, it's an epidemic because the metabolic syndrome is associated with obesity, specifically a type of obesity that occurs mainly in the abdomen, in the trunk. It is called apple-shaped obesity because it looks like we carry an apple in the belly. No, there are two types of fat people. There are people that are fat in the trunk, but the extremities are relatively thin. Yeah. And if there is the belly button, you define this type of obesity by an increased waist circumference. So what defines this central obesity is an increase waist circumference. You don't need to know this, but it is said that it's more than 35 inches for women and 40 for men. There is another type of obesity. I don't know if you've seen that, okay, in which the person is, especially seen in women, no? The person, I'm exaggerating a little, but the person is like this way, no? Is big hips, big caboose, big uh, 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 but the waist is narrow. You see, this is called apple because pardon, sorry, pear shape obesity because it looks like a pear, no, like a pear. Okay, so now you know what these are, the difference of the fruit, okay, in relation with the central obesity. People that have this kind of obesity can be very young, can be children, can be adolescents, can be young adults. Ese conmigo, is this with me or just an open microphone? Open microphone. Okay. And these kind of people um, um, gather in one diagnosis the obesity, pre-hypertension, so a condition in which the blood pressure is not still 140 over 90, but it's not the normal 119 over 79. So it's in the middle. And you know that it's called high blood pressure. It's not hypertension, but high blood pressure. It's like a pre-hypertension. And they are not yet diabetic, but they have glucose intolerance. So we can say like it's incorrect. This is not the correct term, but let's see that because for test purposes, we can understand that. Pre-diabetes, okay, is a client that have glucose intolerance. And the most important, they have high LDL, high triglycerides, and low HDL, the perfect combination to suffer the progressive growth of the plaque of atheroma. You know, this is the metabolic syndrome. Metabolic syndrome in some clients have a characteristic in the skin that is very curious. That is the skin in the neck, the skin in the armpit. Mute your microphone. Mute your microphone, please. The skin between the legs. So for a change becomes hyperpigmented and thickening, has a velvety aspect with these groups that you see here, no? And it is called acanthosis nigricans. Okay, it is a condition associated with this metabolic syndrome. I'm so sorry, guy, but you know there is a very common condition, the coronary artery disease, and there are a lot of questions in English about those topics. So is my suggestion for English purpose, okay, that you master the risk factor, etc., because it's what we can do nowadays. When a person has the angina, as we said, those people usually are prescribe nitroglycerins to be used, either sublingual PRN as needed for chest pain, or around the clock. Okay, around the clock. Around the clock, very frequently they use patches of nitroglycerin. Okay, there is a very economic form of patches of nitroglycerin that I hope you saw in the lab when you practice this theory. Um, that comes like a toothpaste, a tube, is a nitroglycerin ointment and is accompanied by a pack of papers like this. And doctors prescribe the nitro ointment in centimeters or inches. And then we apply like a toothpaste, the amount, the length that is prescribed by the doctor, and we put that in hairless skin of the client, but we need to tape it with tape. Okay. Um, Recently, by the way, This is left there 12 hours, 12 hours, okay, 12 hours. And the ointment is quickly absorbed through the skin. Um, Recently has been an interesting question in Nclex. What happens if this patch, because it's frequently, they ask you a lot about this economic way of administering patches of nitroglycerin. By the way, this is the one that you know that covers Medicare, and that's why it's so frequently used. There are other patches that brings stickers, okay, and but are much more expensive. Okay, so the question says, what do you do if the patches fall? Okay, guys, once the ointment is in contact with the skin, is absorbed. If the patches falls, it's not healthy to apply again another patch because you are overdosing the clients, and then the side effects, which is hypotension, can appear. This vasodilator effect of the nitroglycerin is expected, is normal, is expected, not normal, expected that produce a headache. Usually doctors prescribe Tylenol for this possible complication. And and also flushing, okay, flushing of the skin. Okay, what else, Bajing? Okay, this is about the nitroglycerin. In relation with the antiplatelet medication that the client's taking, can be aspirin, can be any of the grails. What are the grails? Clopidogrel, prasugrel, okay? Prasugrel, clopidogrel, to everybody know, no? Prasugrel, okay? Ticagrelor, okay? You see that all are the grails. We call the grails. Okay? Clopidogrel, prasugrel, ticagrelor. Yes. So those are the other antiplatelet. But please remember that it is one called dipyridamole. Here is the Y. Dipyridamole, the percentin, dipyridamole, it is an E. Okay, it is also an anti platelet aggregation. Okay, because has been have been coming, and some of you don't know those other anti platelet aggregation, and it's important, has been tested. What else? Those clients are taking statins, all the statins, and they can be also taking medication to slow down or calm the heart, to prevent the over exercising of the heart. And those medications that doctor prescribe in client with angina, okay, are beta blockers. Beta blockers. The beta blockers are chronotropic negative medication. Chronotropic negative means that they slow down the heart. They slow down the heart. You understand? And beta blockers are frequently used to put the heart in peace, to prevent the heart from getting too excited and demanding too much oxygen, having the coronary arteries partially obstructed. When a myocardial infarction already occurs, when a myocardial, where is it? Where is it? Just a moment, guys. When a myocardial infarction already occurs, the best of the best interventions is the cardiac catheterism. As soon as possible, doctors are going to introduce a catheter through the aorta, okay, through the aorta, okay, and can be through the groin or through the arm, but the most commonly is through the groin, through the femoral artery. And then they are going, let me see, I can find a good picture. I don't have any good picture. Okay, this could be a good picture. Okay. They introduce, okay, a catheter through the femoral artery, and the catheter advances through the aorta, okay, through the aorta. And here is where the coronary arteries are born, in the root of the aorta. So they can enter the coronary artery and they can inject iodine, and they can see in the fluoroscopic image in a screen with X-rays, they can see where the artery is obstructed. This is the catheterism. The catheterism allows the doctors ¿cómo se llama? To introduce there a balloon, a balloon. The balloon is inflated and is going to open the narrow space. And any clot that could be formed there can be suction, can be removed. You understand? And then a stent, which is like a mesh that is open there, is deployed there to keep it the artery open. Okay, so this is a percutaneous transluminal coronary angiography. Yeah, um, and with a stenting, with a stenting. Yes, is how they call that. Okay, uh, the angioplasty is the name to abbreviate angioplasty. Okay, angioplasty. I always say to remember that, that isn't like a plastic surgery. When we have a big belly, we can have a plastic surgery to remove the fat. Okay, something like this. Okay, angioplasty. Okay, percutaneous transluminal coronary angioplasty. Sometimes this procedure cannot be done because the obstructions is too severe. In that case, they need to open the chest and open heart surgery. And they can't do a bypass. The bypass, when it is too obstructed, is making alternative via. So they can take, if the obstruction is very severe, they can make a hole here and a hole here, yes, and they can put here, okay, a piece of vein, for example, and they fix this with stitches, no? So now the blood has an alternate wave of flowing. So now the blood that cannot pass through the obstruction is going to pass through the bypass, okay, toward the heart. This is a coronary artery bypass graft or cabbage, okay? It requires open chest surgery. Of course, notice the wound. Try to imagine how painful is this wound to take a deep breath, to cough, or to move, and understand the importance of stenting, sorry, of splinting, so pushing with a pillow on the wound when you are moving, the importance of giving analgesics, the importance of the respiratory exercises with its incensed spirometer, etc., to prevent atelectasis in pneumonias, etc., etc. Because sometimes they use a vein obtained from the thigh. This client, a part of the chest wound that you observe here, could have a wound in the thigh that is also needing wound care, and is, by the way, very painful. Very painful. Okay, so those are the most important interventions. In the past, when this catheterism was not so generalized, available, okay, generally available in the hospitals, the 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 way of reestablishing the obstruction. Remember that the plaque was broken, and we have a clot, okay, a clot there. It was the use of the thrombolytic medication. You know that thrombolytics is the only substance that can dissolve a clot and reestablish the circulation. And this thrombolytic therapy is a group of medication that are the family is called the family of this medication is called ¿por qué no me cambia el color? Okay, because I didn't change. Sorry. Is the recombinant tissue plasmin activator. Okay, it's TPA. And those medications ends in A's because are enzymes, streptokinase, urokinase, alteplase, techneteplase, etc. Okay, alteplase is the most commonly used in myocardial infarction and techneteplase. Okay, so this kind of medication is very potent. The clot can be dissolved, but don't forget that the main side effect of this medication is bleeding. The bleeding can be in the GI, okay, with melena or hematemesis, but the worst complication is the bleeding in the brain because the brain hemorrhage can be catastrophic as a complication in those patients. So any neurological change that occurs after administering those medications are priority if you have that in a Nclex question. Okay. Don't forget that patients with myocardial infarction um, are susceptible of sudden death. And the sudden death occurs because ventricular fibrillation. But the ventricular fibrillation can be anticipated or suspected that can soon happen if we observe in a client with myocardial infarction or any ischemic coronary artery disease, the presence of premature ventricular contraction. The premature ventricular contractions, the PVCs, are asymptomatic, are not going to produce significant alterations in the cardiac output of the client, but can be the announce uh, of the BTAC or the ventricular fibrillation that are the ways that people with myocardial infarction can experience sudden death. Sudden death. Summarizing, client described as having a myocardial infarction presents PVCs immediately as soon as possible must be reported because medication must be used to prevent the evolution of the PVCs into BTAC or ventricular fibrillation. The most common medications used to prevent this are the lidocaine, procainamide, that is in the same family, and the amiodarone. Okay, those are the most commonly used medication to stabilize this irritability of the myocardium when there is ischemia to prevent this more serious complication. I think that those are the most important aspects that you need to master in relation with the coronary artery disease. Okay, for both, if you're still dealing with the school tests, and what I have more experience for the Nclex with the level of question that they ask in Nclex. Guys, in a myocardial infarction, the priority is to eliminate the pain. Because meanwhile, the client is having pain, it translates that necrosis or death of heart, of myocardium is happening. That's why the first intervention is to administer the nitroglycerin, no? But if the nitroglycerin is not enough to eliminate the pain, the next intervention is the administration of morphine. The morphine is not only appeasing the pain, blocking the mechanism of perception of the pain, is also a potent vasodilator, especially vasodilator of the small circulation of the pulmonary circulation. This is going to decrease the oxygen demands of the myocardium, the ischemic myocardium, and it's going to limit, just to limit the size of the myocardial infarction, the progression of the myocardial infarction. Because myocardial infarction doesn't occurs at once, occurs by layers. Yes, by layers. When you have a client having a myocardial infarction, okay, you have the first layer of the cells die, then the second layer, then the third layer, by layers. You understand? And you have time to reestablish the circulation. It's called reperfusion. Reperfusion is when you reestablish the circulation. It's what doctors do, okay, in those patients, reestablish the perfusion to save, okay, maybe all those layers already died, but then those layers that were going, the destiny destinated to die, are going to be saved with the reperfusion therapy. Which one are the reperfusion therapy? The catheterism with the percutaneous transluminal coronario angiography and stenting, as we explained, or the open chest, open heart, okay, surgery, the coronary artery bypass graft. When there are not, those resources are not available, for limitation, we are in a small hospital, etc., then the thrombolytic therapy are the possible reperfusion therapies that are the ones that have changed the prognosis of the acute myocardial infarction. There is another interesting, there are many details. There is another interesting detail. Oxygen is not good in myocardial infarction unless the client has low O2 saturation in the blood, which is very rare. Usually, the majority, 90% of the clients with MI have normal O2 saturation. 96, 98% of O2 saturation. They are having, yes, a myocardial infarction, but the ischemia is local. They're in a little part of the myocardium, a little segment of the myocardium, because the pipe that brings the oxygenated blood is obstructed. But in the rest of the body, the oxygenation is adequate. If we give oxygen to those clients as a routine, having the normal O2 saturation evidence, you can find that in the literature. You can go to the online. You don't need to go to the library. You can go to your Singhal. You can go there and look for this evidence-based practice. Is research have demonstrated that giving unnecessarily oxygen to clients with MI and normal O2 saturation increases mortality. So instead of doing good, you are doing bad. You are harming. You need to have this knowledge. It's an update because maybe you are still with the MONA. Morphine, oxygen, nitrate, aspirin. And by the way, it's not in this order. First is nitrate, and second morphine if the nitrate is not enough. But you know, the MONA is something that a lot of people, okay, oxygen is conditioned. Conditioned by what? Is given only if, is given only if the O2 saturation, is below 95%. Okay. Those are details that have been tested because this is already in Nclex. Okay. It comes to my mind, okay, about question that can go around this topic of the coronary artery disease. Guys, any question? Very good. Yo creo que you are sleeping, but okay. Okay, so let's see the other question that is in ATI about cardiovascular disease. A nurse is providing teaching to a client who has atrial fibrillation and reports dizziness and palpitation. It is common. It is common that you feel palpitation because atrial fibrillation is a very irregular rhythm. So you don't feel the normal beats of the heart that you are used to and you can ignore because you take that for granted since you were the fetus and you don't perceive the beats of your heart. But now the heart is beating fast and irregular. You feel this like a flutter in your chest and a fluttering in your chest, and it is what is defined as palpitation because this irregularity can affect the volume of blood that the heart pumps each time that contracts. I mean the stroke volume and the cardiac output. Then our brains that are in the uppermost parts of the body um, can feel um, dizzy because not enough blood with oxygen is reaching the brain. Which of the following should the nurse understand is the cause of this manifestation? Well, I think that I explained that. No? The options are the SA node. You know that the SA node is the one that is designed by nature to generate the electrical impulse, the electrical potential, the potential of action potential that makes the rest of the heart contract. And the SA node sends an electrical signal greater than 100 bits per minute. It is not. It is wrong. It is not true. It is not true. In atrial fibrillation, the SA node practically is inhibited, is overwhelmed, is overcome by hundreds of areas in both atriums. So let's say hundreds as like more SA nodes that are producing electricity in a chaotic way in the atriums. The mess, the racket is in the atriums, not in the ventricles. And instead of having only one area of the right atrium, which is the SA node, producing the electricity, you have hundreds of multiple areas in both atriums producing electricity. So it is not the SA node that is responsible of this mess that is the atrial fibrillation. If you have an SA node producing more than 100 beats per minute, it is called sinus tachycardia, which is what happens when you are running or when you are excited or when you have activation of the sympathetic nervous system. So rule out that. The heart's electrical signals are rapid, chaotic, and irregular. Well, it sounds more possible, yes? So there is electricity generation in both atriums, very rapid, very chaotic, and very irregular. I like it. It sounds more like an atrial fibrillation. The other says the heart's electrical transmission through the AB node is unusually slow. This is an atrioventricular block. And this produces a slow rhythm, bradycardia. So this is not nothing to do with atrial fibrillation. It's not the cause of the symptoms, okay? So it is not. Although, well, it is too deep. It is complicated. So, but you can have at the same time atrial fibrillation and AB block, but it's not the purpose. It's not, let me not confuse you. This is not true. It is AB block, not atrial fibrillation. Let's see the last. An early electrical signal occurs before the expected sinoatrial node signal. No, it's a PB. It is a supraventricular premature contraction. This is only one bit that is happening before time. So it's a premature, but instead of ventricular, supraventricular or atrial contraction. Yes, so it is not. So the one that I choose is the best. Let's see. Okay. They agree with us. Atrial fibrillation causes electrical stimuli to be sent from multiple areas in the atria and transmit electrical impulses that are rapid, chaotic, and irregular, causing manifestations such as heart palpitation and dizziness. Remember that this chaos can produce, in some moments, an insufficient cardiac output, and that's why the brain, okay, the brain can suffer, okay, almost syncope or dizziness, etc. Okay, pre-syncope, etc. Don't confuse this with the embolization of clots to the brain, which is something that happens also in atrial fibrillation, but it is more devastating. The dizziness is transient. The embolization is permanent. Okay, is permanent. Um, Sign of tachycardia occurs when the SA node is beating more than 100. We knew that. First degree heart block occurs when there is a slow conduction between AB node. Okay, we knew that there is an AB block. And premature atrial contractions occur when irritated atrial tissues fires an impulse before the expected, okay, beats. Let's talk a little about atrial fibrillation to solidify the concepts, okay, solidify the concepts about this so important cardiac dysrhythmia. Uh, in atrial fibrillation, instead of having only the S node that should be here in the right atrium producing the electricity, you have hundreds of different areas of the atriums, both atriums, producing electricity in a chaotic and irregular fashion. As a consequence that you have a rapid, generally rapid, irregular rhythm that is passed to the ventricles. The ventricles are not in this chaos. The ventricles are, organized. There is not this racket that we have in the atriums. The ventricles are pumping. Thanks God. When we have ventricular fibrillation, we are dead, kaput, and se acabó. Yes. Atrial fibrillation is compatible with the life. By the way, it's very common to have chronic atrial fibrillation. And when you have chronic atrial fibrillation, you can drive, you can walk, you can teach Nclex review, you can do whatever. Yes. So atrial fibrillation, don't confuse that with ventricular fibrillation. If you have ventricular fibrillation, you are dead and you need to be resuscitated. Atrial fibrillation, atrial fibrillation has as a consequences, okay, as a consequences, a very fast, and irregular production of electrical impulses that are passing to the ventricle. So the client has tachycardia in an irregular beats. And for that reason, the client feels the palpitations. And from time to time, some of the beats are so rapid or so chaotic that they don't pump enough blood to the brain, and the patient can feel fainting, transient, se llama reversible fainting or presyncope or almost passing out. But the serious problem of the atrial fibrillation is that because this chaos in the atriums are not emptying totally. And there are some areas of the atriums, it's like a corner of the atrium called the appendage, where the blood becomes very stagnation is not moving. And when the blood is not moving, and it happens only in atrial fibrillations and atrial flutter. Atrial fibrillation and atrial flutter for test purposes for you is the same. Okay, the differences are in the morphology of the EKG. Okay, is different. The EKG of the AFib and atrial flutter can be differentiated, can be discriminated by the expert. But for test purposes, what is happening in the pathophysiology is the same. So now this clot that is forming here can move to the ventricle. And remember that in the case of the left ventricle, what you have leaving the left ventricle is the aorta, and the aorta goes to all over the body. So this clot can go to any part of the body, can go to the legs, to the arteries of the legs, producing, a gangrene in one leg, can go to the kidneys, producing an infarction in one kidney, can go to the whatever. But more frequently, because the aorta, makes a curve, okay? And from this curve, from this arc of the aorta, the carotid arteries that go to the brains are direct branches. So very frequently, the first site that those clots have to take is the carotid arteries. So very frequently, those clots go to the brain, producing brain infarction, a stroke, and the clients will be having a hemiplegia. And it's called thromboembolism because it's a thrombus, okay? This is a thrombus embolism, okay? Because it's embolized from the heart to the brain. For that reason, patients that are having atrial fibrillation need to take chronically two medications. One medication is to prevent the formation of those clots in the appendage, in the corner where the clot forms, and those are the anticoagulants. If the client is suffering of chronic atrial fibrillation, as I said before, is going to live his or her rest of his or her life with this atrial fibrillation because it's chronic, and for that reason need to take for the rest of his or her life an anticoagulant. Need to take the anticoagulant at home, so need to be an oral anticoagulant. Those anticoagulants, the oral anticoagulant must be known by you, is the warfarin. Warfarin the dose need to be adjusted with the INR, keeping the INR between 2 and 3. But now we have new oral anticoagulants, the novel oral anticoagulants that are already in English, like the dabigatran, the apixaban, and the rivaroxaban, okay, that are novel oral anticoagulants that have a big advantage over warfarin. They don't need an adjustment of the dose with the INR. There is no need of doing the INR. The dose is standard. And the second advantage, they are not related with the vitamin K. So the diet shouldn't be controlled, restrained in their intake of vitamin K rich food, like in clients with taking warfarin. And also the risk of bleeding is much, much lesser in those novel oral anticoagulants. They are already in Nclex, guys. Okay, they are already asking, and what they ask, I just said, the advantages mainly, because what we have about this is advantages. Remember, they don't have anything to do with the vitamin K, so the antidote for them in case of bleeding is not the vitamin K. Okay, so the antidote doesn't exist for them. Exists, but it's not for nurses to know. It's very complex. Just a discontinuation of the medications usually is enough to stop the bleeding. The administration of coagulation factors, the prothrombin complex, okay, is the usual treatment in those cases. They are monoclonal antibodies, but that can be used as an antidote. But this is not, don't expect this to be the Nclex question, like the vitamin K and warfarin, that is still the antidote of the warfarin. The other medication that the patient with chronic atrial fibrillation need to be taking the rest of his or her life is something for the tachycardia, the the frequent, just the tachycardia. And those medications are the chronotropic negative medication. There are three chronotropic negative medication that you need to know. The calcium channel blockers family that slow down the heart, that specifically are the diltiazem and verapamil, the beta blocker, and the dioxin. Those those three medications, those three family of medication, digitalis, the cardiac glucoside, the beta blockers, and the calcium channel blockers, specifically diltiazem or verapamil, are chronotropic negative. So the client will be taking or a tablet of, I don't know, metoprolol, which is a beta blocker, or a tablet of diltiazem, verapamil, or a tablet of dioxin. Doctor will decide depending of the other characteristic of the client. But any of one of these three chronotropic negative are usually prescribed together with the anticoagulant, the oral anticoagulant, to clients with chronic atrial fibrillation to make them live with this arrhythmia without consequences. Sometimes doctors consider that it's worthy to attempt revert revert to come to take back the AFib into normal sinus rhythm. If they decide to do that, they do through something called cardioversion. 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 The cardioversion can be chemical or electrical. If the cardioversion is chemical, they can use medication like the amiodarone or the propafenone. Both are being in Nclex. So doctors administer those medications to revert the AFib to normal sinus rhythm when they consider convenient. Yeah. The other possibility is the electrical cardioversion. So it's an electrical shock under sedation because it's painful, but need to have a characteristic, need to be need to be synchronized with the EKG, because the electrical shock need to be delivered in the moment in which the shock is not harmful for the rhythm. And that's why a button that is in the cardiovector in the machine to do the electrical shock need to be pushed. The button that says synchronization, the sync button, because mandatorily in this kind of client, the electrical shock must be synchronized, and that's why it's called electrical cardioversion. When clients have ventricular fibrillation, which is another completely different condition, is a life-threatening condition that is equivalent to death, the client will receive an electrical shock, but asynchronic, without synchronization. And this electrical shock is called defibrillation. Defibrillation. So there is a big difference between the electrical shock called cardioversion, electrical cardioversion, and the electrical shock called electrical defibrillation. Yeah? This is synchronized and this is non-synchronized. Non-synchronized. Yes, non-synchronized. Okay, very good. So those are the options for clients with with atrial fibrillation. The options. By the way, before I forget, if the client with atrial fibrillation is going for a chemical or electrical cardioversion, it is mandatory to have, previous to this procedure, a transesophageal echocardiogram that demonstrates that there are not clots in the atriums. Because if there are clots in the atriums and they put to beat again those atriums, then the clots are going to be pumped to the brain and a disaster. Why they need to do this echocardiogram through the esophagus and not through the chest as usually is done? Because atriums are incompletely seen through the transthoracic echocardiogram. Need to be done through the esophagus, the echocardiogram. Understand that a transesophageal echocardiogram has the same requirements as an endoscopy, an upper GI endoscopy. The clients need to be MPO, the clients need to give consent, the client is going to be sedated, cannot drive back home. The client is having the throat numbed by local anesthetic, so has inhibited the reflexes like the gag reflex that are protecting against aspiration, so cannot eat or drink after the procedure until the anesthesia wears out. And of course, need to be observed, okay? Observed, okay, after this invasive procedure. Okay, those are the main aspects of this dysrhythmia that is so important that I think, again, could be tested in you. Okay, so this is, we agree totally with this statement. Atrial fibrillation can cause electrical stimuli to be sent from multiple areas in the atria and transmit electrical impulses that are rapid, chaotic, and irregular, causing manifestations of heart palpitation and dizziness. No question, guys? Okay, let's see the next question. A nurse is teaching a client who has dilated cardiomyopathy. Okay, this is Latin. We need to learn Latin to understand the medical terminology. Cardio is heart, and myo is the muscle of the heart, so the myocardium. Pathy is disease. So the cardiomyopathies is a group, not only one, a group of diseases, okay, that affects mainly or primarily the myocardium, okay? And we have basically three types. The most common, that is the dilated, where the muscle is severely damaged and then stretches, dilated, and then you have a big heart, ¿cómo se llama eso? A cardiomegaly. You have also a form of cardiomyopathy where the muscle is replaced by fibrous tissue. The muscle of the heart is very elastic and compliant, can stretch to fill with blood and can efficiently contract to speed to pump this blood forward. Okay. In the dilated cardiomyopathy, this muscle is thin. The thickness is thin and weak. So it's mainly having problem to during systole to contract and speed pump the blood forward and produces heart failure, the classical heart failure. And you know, the heart is seen very big in the X-ray and the echocardiogram. The restrictive cardiomyopathy, in contrast with the dilated, the muscle is replaced by a stiff tissue that decreases the elasticity or the compliance of the myocardium. For that reason, the main problem is during diastole, when the normal myocardium is able to stretch to fill with a lot of blood inside, there is a restriction to this diastole. And the amount of blood that can enter the ventricle to be posteriorly pumped forward is decreased. It's called restrictive cardiomyopathy. And the other one is called hypertrophic. Hypertrophia is, or hypertrophy is when a part of the body becomes bigger than normal. But let's see, bigger than normal, like the muscles of people that are bodybuilders, not the bodybuilders, those people that are very muscular, okay? Like the technician of the emergency in the ambulance, okay, those guys, yes, that had very big muscles, okay. In that case, the myocardium exaggeratedly uh, hypertrophic, especially in in the in the wall that separates the right from the left ventricle. It's called septum, the ventricular septum. And there is a door. There is a door through which the blood leaves the ventricle to go to the aorta. This door is the exit for the blood is obstructed by this too thick wall, too thick septum. And then the blood has problems to lift the ventricle when there is a systole. By the way, this hypertrophic cardiomyopathy is the responsible of those athletes, young, healthy, athletic people that suddenly die, suddenly suffer cardiac arrest while practicing sports that I'm pretty sure many of you have heard of. Yes? It is that. That's why here in Florida there is a law that to practice sports in the school, in middle school and high school, you need to have a evaluation of the physician, of the pediatrician or the physician that rule out this condition. That can be ruled out with echocardiogram and electrocardiogram. Okay, because it's not good to practice sports having this condition because you can suffer sudden death. Okay? So summarizing, there are mainly three types of cardiomyopathy or primary disease of the myocardium, because remember, the infarction is secondary. Secondary to what? To the coronary artery disease. Yes? But in this case, it's a primary problem in the myocardium. That's why it's called cardiomyopathy. You understand? And are they dilated, which is probably the most common. A very thin muscle, but very stretched, dilated, like a gelatin, like a, no sé, like my belly, okay, like something there that is shaking. Yeah, it's not strong enough as to produce an efficient systole, and is associated with heart failure. The restriction in which the myocardium, instead of being elastic and compliant during diastole to stretch and fills with blood, is too rigid, too stiff, and restricts the amount of blood that can enter during diastole, which, as a secondary consequence, restricts the amounts of blood that can be pumped during systole. And the hypertrophic cardiomyopathy, in which the heart that is a muscle builder, yes, muscle builder, and it obstructs. It's an obstructed hypertrophic cardiomyopathy because then the blood wants to live but cannot live. Why? Because there is an obstruction in the way. Okay, and it's cause of sudden death. Okay, so now that we make this a little review of what is cardiomyopathy, that, by the way, in my opinion, it is very specialized. But who am I to say that? Okay, but it's a very specialized question. Okay, but well, I try to simplify that for you. Okay, So once that we review this, the nurse is teaching a client who have dilated cardiomyopathy about this condition. Which of the following statement by que hice? No, by the nurse should include in the teaching? Let's see. Your heart condition is caused from stiffening of the walls of the ventricle. This is restrictive, not dilated. Your heart condition is caused when the ventricular tissue becomes fibrous and fatty. Is the same. Is the restrictive. Your heart condition is caused by excessive stretching of the ventricle. It is possible. Too much dilation, too much stretching. Your heart condition is caused by thickening. Now, thickening is the hypertrophic of the ventricle walls and septum. So I think that the best should be this. Let's see. Okay, your heart condition is caused by excessive stretching of the ventricle. Correct. Dilated cardiomyopathy is a progressive cardiac anomaly that occurs when dilation of the ventricles impairs the heart's ability to contract. So it's the systole, the moment that is most affected, because it's like a gelatin and very big, very stretched. You see the heart very big. Okay, it's a dilated cardiomyopathy because it's thinning and stretching of the walls of the ventricle. Your heart condition is caused by thickening of the ventricles and wall is the hypertrophy. You see that hypertrophic cardiomyopathy is a cardiac disorder that results from hypertrophy or thickening of the left ventricle walls and septum, and is obstructive. It's obstructive, okay? Not all are obstructive, but this is the obstructive hypertrophic cardiomyopathy that can produce sudden death in young, healthy people. But by the way, this condition tends to run in families, have a strong genetic influence, okay, that need to be screened in all the family if one case is diagnosed. And is the one of the athletes when those el hijo de LeBron, no, had that, no? LeBron child had that, no? And who else? A lot of people, athletes have even have died. Okay, a famous football, no, soccer players in England. Oh, a lot of people have suffered that. Arrhythmiogenic cardiomyopathy. All the cardiomyopathy can be arrhythmiogenic. I don't agree with that. But restricted cardiomyopathy is cardiac stiffness of the ventricle, which causes a decreased diastolic. Yes, the feeling during diastole is the one that is restricted. Okay, I hope that it helps you to differentiate cardiomyopathy in case you have a question like this. A nurse is teaching a client who has pericarditis. Okay, pericarditis is a disease of the pericardium. Okay, it is the pericardium. Okay, which of the following statements should the nurse include in the client's teaching to explain the cause of pericarditis? Okay, the most common cause is an inflammation because pericarditis is inflammation. But there are many causes. The most common cause of pericarditis is viral pericarditis. In medicine, the most common cause of pericarditis is viral. But there are other causes of pericarditis. You can have traumatic pericarditis because chest trauma. The pericarditis can accompany myocardial infarction. Pericarditis can be a manifestation of autoimmune diseases like lupus. Lupus, okay, love to produce pericarditis. Pericarditis can be bacterial. Pericarditis can be seen in clients with renal failure, end-stage renal disease, when the urea is too high, when there is uremia. There is a uremic pericarditis, okay? So there are a lot of cause of inflammation of the pericardium. You need to know, that the heart, I think I have pericarditis here. The heart, yes, here is. The heart, okay, is surrounded by the pericardium. So the heart is surrounded by the pericardium. The pericardium has two layers. One layer that is attached to the heart is the visceral pericardium, and another layer that is attached to the walls of the mediastinum. Okay, so it's a double layer, the same as the pleural membrane. The space between these two layers is virtual, so nothing should be there except a microscopic layer of liquid. Microscopic, okay, layer of liquid. Okay, sometimes there is A, B, or C condition that produces case, no sé, uh, that produces inflammation of the pericardium. Okay, let me change the color of the piece. I mean, put it in green. Okay, so produces inflammation of the pericardium. Can be viral, can be, ¿cómo se llama? Lupus, etc. So now you have an inflammation of the pericardium. What happens now when you have inflammation? These two layers that are sliding one over the other. Each time the heart contracts and dilates. So each time the heart beats. Each time the heart beats, okay, the heart beats. The uh, parietal slides over the visceral layer of the pericardium. Normally, these two layers are very smooth and lubricated by this microscopic layer of liquid that I mentioned should be there. So there is no friction generated when the normal pericardium slides one over the other layer. But when there is inflammation for any cause, then the surface of the pericardium becomes rough. And when they slide one over the other, they produce a sound, a grating sound of two surfaces that are rough, like sandpaper, that are sliding one over the other. And this sound is called pericardial rub. Pericardial rub. Usually, because the pericardium is inflamed, this rub frequently produces pain. The pain is in the chest, but it's not pressure like the pain of the myocardial infarction or the angina. And this pain has a characteristic, is tested. If the patient is resting, leaning forward. So this is the client in bed, no? I'm trying to draw the client in bed. You see the client leaning forward with a pillow here, holding the pillow, hugging the pillow like this. You see the client, this is the bed. Oh, this is the bed, no? This is the bed, okay? This is the bed. You see the client, okay? You see the client in this position in bed, okay? This is the client in this position in bed. Qué feo me quedó este viejo. This is the client in this position in bed, okay? Leaning forward. Ojo, attention, this has been tested, which is the antalgic or anti-pain position in pericarditis, leaning forward. Okay, leaning forward. Do you force the client to recline back? No. Respect this position. It's a comfort position for the client. Okay. So this is the, the acute pericarditis in their initial phases. But then sometime, ahora sí me pone el azul. Sometimes liquid starts being spilled between the two layers of the pericardium, the visceral and the parietal. So now it changes. Now it is called pericarditis with pericardial effusion. Pericardial effusion is the spills of liquid between the two layers. Can be little liquid, can be moderate liquid, or it can be a lot of liquid. Once the liquids start building up there progressively, then a phenomenon will occur is when you place the stethoscope in the chest, it's very difficult to hear the heart sounds because you know that the sounds don't transmit well through the liquid. And you can notice that if you go to the swimming pool and you dive or put your head in under the water and you don't hear anything. Yeah. So now the heart sound, the tum tum, tum tum, lop dop, lop dop, it becomes very muffled, very distant, very decreased. Yeah. And this is a phenomenon that occurs when there is liquid building up in between the two layers. The risk of this pericardial effusion is that the amount of liquid can be so important that squeezes, strangles, constricts the heart, and the poor heart cannot cannot dilate, cannot go to diastole. Why? Because the ¿cómo se llama? The amount of liquid is constricting. Okay, is you know uh, squeezing. Okay, the heart, and then the heart cannot fill with blood. If the heart cannot fill with blood, what happened with the blood that must enter, the blood that must enter the heart cannot enter. Why? Because the heart cannot allow the blood to fill its interior. So the diastole is restricted by the pericardial effusion. So now you are going to notice that all the veins are engorged, are yes, distended, especially the neck veins, because the blood, the venous blood, is waiting to enter into the heart. But if the blood is not entering, the blood is not living. Yeah, the blood is not living. So a part of having this muffled heart sound, a part of having this distension of the veins, especially the neck veins, you are going to have a decreased cardiac output and a decreased blood pressure. This triad of having muffled heart sound, neck vein distension, and hypotension with decreased cardiac output is called the Beck triad and is characteristic of the most severe complication of the pericarditis called cardiac tamponade, which is a obstruction of the flow of the blood flow through the heart, which is lethal, is mortal, because it produces obstructive shock, because the blood is not moving, because blood is not being pumped out of the heart, the blood pressure drops, so you enter in shock, in an obstructive shock, But it is a sequence, it's a continuum, that is happening along the time in a pericarditis. Of course, the cardiac tamponade is an emergency. The intervention is this: quickly, a needle must be introduced in the pericardial sac to remove some of this liquid. When the liquid is removed, the heart can then expand during the diastole. The blood can finally enter in the heart, and the blood is going to be pumped to the aorta, so the blood pressure will improve and the neck vein distension will decrease. It's interesting that among the phenomena that produces this low blood pressure, there is something called paradoxical or weird. Paradoxical means weird, okay? Pulsus paradoxus or paradoxical pulse. And it's something very funny, is that when you are checking the radial pulse of the client, you are checking the radial pulse, as you know how how to do, no? You notice when the patient breathing, you know what is it? When you, suck the air in the lungs, breathing, the pulse disappears. No pulse. You say, oh my goodness, the patient died. No, it's not dead. It's alive. But you don't feel the pulse. It happens because the blood pressure drops too much, even more than, than, than previously. But then when the patient breathe out, breathe out, then the pulse reappears. You feel again the pulse. So it's a pulse that disappears when you breathe in and reappears when you breathe out. It's very weird, no? And in Latin, weird is called paradoxus. It's a pulsus paradoxus. And it's because the blood pressure drops even more than previous during inspiration, and elevates, go back a little, recovers a little during expiration. Okay, pulsus paradoxus. Okay, well, a brief review of what is pericarditis. Let's see if we can deal with this information with the question. What happened with the question? Okay. What's this? Okay. And the problem, the question is about the cause of the pericarditis. Let's see. Your heart condition is caused when the ventricular tissue becomes fibrous and fatty. No, those are the cardiomyopathy. This is restricted cardiomyopathy. Your heart condition is caused by excessive stretching of the ventricle. No, it is another cardiomyopathy. This is a dilated or just dilated cardiomyopathy. Your heart condition is caused by thickening of the ventricular walls and septum. No, this is the hypertrophic cardiomyopathy. Your heart condition is caused by stiffening of the walls of the ventricles. Oh my goodness. What is the answer? Okay, pericarditis. Pericarditis. With the following statement should the nurse include in the client tissue to explain the cause of pericarditis? Your heart condition is caused by when the ventricular tissue becomes fibrous and fatty. It is a myocardium. It is a myocardium problem. It is a restrictive cardiomyopathy. Your heart condition is caused by excessive stretching of the ventricle. This is dilated cardiomyopathy. Your heart condition is caused by thickening of the ventricular. Those are the options of the previous question. No? It's caused by thickening of the ventricular walls and septum. No, this is the hypertrophic cardiomyopathy. Your heart condition is caused by stiffening of the walls of the ventricle. This is restrictive. I don't know how to answer this question. Let me close a moment to be sure what we are dealing with this. Okay. Pericarditis. A nurse teaching a client who has pericarditis. Which of the following statements should the nurse include in the client teaching to explain the cause of pericarditis? Beautiful questions. Okay, rationale. Your heart condition is thickening of the ventricular versus sector. The cause of ventricular tissue becomes fibrous and fatty. Your heart condition is stiffening of the ventricle and condition excessive stretching of the ventricle. Can you help me? I don't know what to say. Let's answer anyone to see what they say. Okay, they say the correct is by your heart condition is caused by stiffening of the walls of the ventricle. Pericarditis, a common cause of chest pain, occurs when the pericardial sac of the heart becomes inflamed. I think that there is a divorce, there is a lack of aligning of the options in the answer. Okay, so I think that this question is wrong. Okay, I hope that you don't have this question on your test. Okay, hypertrophic cardiomyopathy is a cardiac disorder that results from hypertrophy or thickening, which is okay, thickening, yes. Your heart condition is caused by the ventricular tissue become fibrous and fatty. Cardiac tamponade occurs when there is an excessive accumulation of fluid greater than 200 milliliters in the pericardial sac. There is not relation between the rationale and this option. Your heart condition is caused by stiffening of the walls of the ventricles. It is myocardium. Pericarditis is a common cause of chest pain, occurs when the pericardial sac of the heart becomes inflamed. This is pericarditis, but there's no correlation with this option. And your heart condition is caused by excessive stretching of the ventricle, dilated cardiomyopathy, dilated cardiomyopathy. Okay, this is okay, but this is not the question. Okay, this question is crazy, so let's ignore this question. Any question, any doubt? It's a wrong question. It's a mistake in the options. There is uh, a lack of alignment, and we discard the question. Okay. The next question. Beautiful question. Rational. A nurse is teaching a client who has peripheral arterial disease. Okay, we know this disease, no? Notice that the peripheral arterial disease is produced by the same process that produces the coronary artery disease. It's the atherosclerosis. It's the process of formation of plaque of cholesterol, but in this case, it's in the arteries of the legs, okay? And usually occurs parallel with the formation of plaque of atheroma in the coronaries and the arteries of the brain. So now you need to visualize atherosclerosis as a very slowly installation disease that have risk factors that we studied, okay, modifiable and non-modifiable, but is affecting at the same time the arteries of the brain with the risk of producing a stroke, ischemic stroke. The arteries of the heart, which are the coronary arteries, with risk of producing angina and myocardial infarction, and the arteries of the legs with the risk of producing peripheral arterial disease. A detail of the peripheral arterial disease, I mean the disease of the arteries of the legs, is especially common in people that smoke and in diabetics. So there is a severe presentation in those two predisposing factors. Okay, so nurse is teaching a client who has peripheral arterial disease. Which of the following statements should the nurse include in the teaching to explain peripheral arterial disease? Okay, uh, it is another question about the pathophysiology of the disease. Okay, blood flow is altered due to excessive stretching of the ventricles, impairing the heart to contract. Now, it is a local problem in the artery of the legs. The ventricle doesn't participate in peripheral artery disease. The ventricle is in the center, so we rule out this. Blood flow is altered and causes blood to pool in the legs. Pooling blood in the legs is venous disease because the blood return is venous, not arterial, and is where the blood can pool in the legs. So this is peripheral venous disease, not arterial disease. No problem, no? The third, blood flow is altered due to atherosclerosis affecting the tissue's ability to receive oxygen-rich blood. Probably yes. Probably this is the right answer. Let's see the last. Blood flow is altered due to incompetent valve. The arteries don't have valve. The heart has valve, but not the arteries. The veins do have, okay? The veins do have valve. When there is incompetent valve, okay, is venous problems, okay? Venous problem, of course, causing increased venous pressure. So the best option need to be C, no? Blood flow altered, yeah, C. Okay, blood flow, correct. Peripheral arterial disease is caused by the plaque built up in the arteries, causing decreased blood flow, blockage, or spasm, leading to deficient oxygen-rich blood reaching the tissue. It's correct. The valve is in the varicose vein, the veins. The blood flow alternating to pull on the leg. This is a venous disease. Okay, pull the legs, the veins become delayed varicose veins, and the cardiomyopathy has nothing to do with the peripheral arterial disease. No doubt, no questions. What else? What we can discuss about peripheral arterial disease? Well, you already saw that in the peripheral arterial disease, the risk factors are the same as in coronary artery disease, but diabetes and tobacco are very important. Yes. And remember that the presentation, the clinical presentation, the initial is intermittent claudication. Intermittent claudication is like an angina, but in the muscle of the legs. When the client is walking, the muscle requires more blood and oxygen to produce more energy to work. And you know there is a partial obstruction of the arteries that supply this blood and oxygen to the muscles. Then appears a relative, okay, ischemia, this balance between the needs and the supply of oxygen, and appears ischemia, appears deviation of the metabolism from aerobic to anaerobic, and the production of lactic acid, okay, creates pain. What must do a client that is experiencing intense pain in the muscle of the legs? Stop walking. Stop walking. When the client stops walking, the demand of oxygen disappears and the pain improves. Yeah, the ischemia disappears, the production of lactic acid decreases, and the pain disappears. And then the client starts walking again. But then after a while, the pain reappears and need to stop again. And then start walking again, the pain reappears and need to stop again. And then start walking again, the pain reappears and need to stop again. And this walking stop, walking stop, walking stop is called intermittent claudication. There is something interesting in the intermittent claudication. In the legs, the arteries can grow branches, can grow collaterals. It doesn't happen in the heart. It does not happen neither in the brain nor the heart. You know? So in the case of peripheral arterial disease, it's good, it's recommended to walk, because walking, even if it produces the pain of the intermittent claudication, this walking will regenerate, will produce new arteries that will bypass the obstruction that previously occurs after years and years of smoking or having diabetes, etc., etc. So if you have this question in your English, a client with intermittent claudication, tell the client the following. Hey, you need to continue walking. When you experience the pain, stop and wait until the pain disappears. But then continue walking and continue walking. And you will notice that if you continue walking, if you continue exercising, and of course you quit smoking, you start controlling your predisposing factor, uh, you will notice that each time you can walk longer and longer distances, and your peripheral arterial disease will improve. It is a common question in English. When a client has peripheral arterial disease, another question, the client prefers to have the arteries depending, pardon, the arteries, no, sorry, sir. The legs, okay, depending, okay, depending. So you see that the patient even sleeps with the legs in dependent position, yeah. Well, because this way is easier to the blood to reach the feet, because the gravity force is helping, okay, is helping in this circulation. If the legs are elevated, okay, elevated in pillows or something like this, yes? Then being this down, being uh, being this the ¿cómo se llama? The bed, okay, the bed. Then the blood needs to flow against the gravity force, and it's going to be difficult to reach the feet. So the symptoms are going to be worst. So dependent is much better. Make sense? Okay, it is another classical. In Venus, problem is the contrary. In Venus, it's better to have the legs elevated because it favors the blood return. It's difficult to have blood return with the legs dangling dependent. Okay, so are totally opposite. Okay, that's why we say in venous problem, be the venous, okay, it's better to have the legs, okay, the legs, okay, up. But in problems, okay, it's better to have the legs, okay, uh, uh, dangling. Okay. In a part of this intermittent claudication, you are going to notice all the manifestation of arterial insufficiency, which is paleness. The legs are pale. Coolness are cold, and very important, the skin and the hair, okay, are affected by the chronic ischemia. So the skin becomes atrophic, like with malnutrition, become thin, very shiny. It's not velvety like the healthy skin, very shiny and very important and frequently tested. There is loss of hair. So you can have a person that usually was very hairy. Okay, there are some people like me that are very hairy. Okay, and then you see that all the hair is lost in the distal parts of the legs. It's a sign of peripheral arterial disease. For example, ankle, how test that ankles? You have a woman that comments to you, the nurse, that she used to shave her legs very frequently, but now she is not shaving the legs. She doesn't need to shave the legs. What disease you suspect? Peripheral arterial disease. Remember that ankles always take the concepts, the knowledge, the content to real life situations, and you need to do your deduction or induction depending on the situation. Okay. The people that have uh, venous disease, they have distended veins, varicose vein, and then develop something very characteristic. Once they develop ulcers, venous ulcers, okay, varicose ulcers that frequency are here in the medial malleolus, in the inner malleolus, in the inner ankle. Yes, inner ankle. They are very irregular borders ulcers and very secreting, very crying, very juicy because a lot of edema. And the most important, frequently tested. Do you see this discoloration, this dark brown discoloration of the skin? You see this? It is characteristic of the venous problems. The pigmentation of the skin. You know what is this? This is iron. This is the position of iron, of the stagnation of the blood along years and years produced the position of the iron of the blood in the skin. And this is the reason for this brown discoloration of the skin. They notice that the skin of client with peripheral arterial disease is pale and shiny, thin, without hair, etc. If they develop ulcers, are very painful ulcers that are punched out, very defined borders, very dry, over bony prominences. Diabetic clients suffer a lot of these ulcers. Okay, so This is okay, trying to make parallel ATI with cardiovascular content, okay, on the questions. Okay, peripheral disease. Let's see these questions. A nurse is teaching a client, oh, again, cardiomyopathy, who has restricted cardiomyopathy. This is the cardiomyopathy while the walls are very stiff and then the diastole is restricted. So the heart cannot fill with blood. And classically, those clients have in the auscultation an S4. Which the following statement to the nurse, this is bothering too much with cardiomyopathy. It is not so important for your English. With the following statement should the nurse include in the client teaching to explain the cause of the restricted cardiomyopathy. Your heart condition is called when the ventricular tissue becomes fibrous and fatty. Your heart condition is called when excessive stretching. No, excessive stretching is dilated cardiomyopathy. Your heart condition is caused by thickening of the ventricular walls and septum. This is the hypertrophic, okay, cardiomyopathy. Your heart condition is called for stiffening of the walls of the ventricle. This is the best. This is stiffness that limits, limits the stretching during diastole. I think that dedicating too much effort to study cardiomyopathy. Uh, okay, it is interesting. A nurse is teaching a group of clients about risk factors of developing peripheral artery disease. Which of the following risk factors should the nurse include in the teaching? Chronic pulmonary disease. COPD is not related with peripheral artery disease unless indirectly through smoking. Cystic fibrosis is not related with this. What other chronic asthma is not related with this? What other disease, chronic pulmonary disease? Okay, no, nothing look like. Body mass index, okay, obesity. Obesity, it can be related with atherosclerosis. Remember that peripheral arterial disease is atherosclerosis, the same atherosclerosis that we studied in a coronary artery disease. Rheumatic fever. Rheumatic fever is a disease that produces damage in the valve of the heart, not in the artery of the legs. And the history of venous thrombosis. Remember, there is a venous disease, and we are talking arterial disease, and we discriminated that. So the best option here is the obesity. That is the only risk factor that we see here for atherosclerosis. Okay. A body mass index greater than 30 is a risk factor for developing peripheral disease because it's obesity, and obesity is a risk factor for atherosclerosis. No problem with that. Um, let's see this. A nurse is teaching a group of clients about risk factor for developing atrial flutter. Remember, for test purposes, if you see atrial flutter, it's the same as atrial fibrillation, the same risk factors, etc. Which of the following clients should the nurse understand is at highest risk? Oh, be careful with this question because maybe all the clients or more than one client is at risk, but then you need to find which one is at the highest risk, okay, of developing atrial flutter. The client who is recovering from a recent illness that caused vomiting and diarrhea is recovering, so it's better. Vomits and diarrhea. How could relate vomiting and diarrhea with the heart? Well, basically, vomit and diarrhea can bring dehydration and electrolyte alteration like hypokalemia, and it can produce cardiac dysrhythmias, PVCs, etc. No? But it doesn't look to be an important risk factor for atrial flutter. Okay, I want to show with you. Oh Lord, what I this. Okay, okay, let me reset. Okay, let me tell you what are the main risk factors for atrial fibrillation. Atrial fibrillation is very, very, very common when the atriums are enlarged by previous cardiac diseases. One of the most common causes of enlargement of the atriums are narrowing stenosis or narrowing of the mitral valve, or mitral stenosis. And of course, if the mitral valve is too narrow, is too narrow, then the blood is going to have problem moving, okay, moving through this narrow valve, and is going to produce distension of the atrium. The stretching or dilation of the atriums can produce atrial fibrillation. Another cause is hypertension. When there is hypertension, okay, hypertension also produce a backflow of pressure to the atriums and can produce a stretching or dilation of the atriums and produce, okay, atrial fibrillation. One common cause of atrial fibrillation is sleep apnea. You should know that is that, no? Some people suffer of this obstructive sleep apnea, obstruction of the soft tissue of the airway during sleep, producing, the snoring and the sleep apnea. Um, and a super important cause of atrial fibrillation is hyperthyroidism. You study hyperthyroidism, you study Graves' disease, okay? You study hyperthyroidism, and hyperthyroidism is a super important cause of atrial fibrillation. So they are structural because the atriums and the valve, okay, alteration that favors, okay, atrial fibrillation. They are hormonal causes. Oh, I forgot something very important. Drugs and medication. Caffeine, uh, of course, amphetamines, cocaine, sympathomimetic stuff are important cause of acute atrial fibrillation. I had in my experience 2 nursing students in different moments that suffers of acute atrial fibrillation after a night of cramming um, before the test and consuming Adderall, which is amphetamine-like, consuming Monsters and Red Bulls, and of course Cuban coffee. No? Uh, 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 it's important to mention that. Okay, it's important to mention that those are um, common causes. But what you need to know is that common, the most common chronic dysrhythmia that human beings suffer, especially while aging, older people, is atrial fibrillation or flutter, which is the same for you. Okay, has differences, but it's the same for you. Okay, okay. So it is a brief comment. Okay, about uh, that they are asking which one is that the highest. Unfair. Okay, the client who is recovering from a recent illness that caused vomiting and diarrhea. Uh, question mark, question mark, very difficult. It's not the most common situation, the one that I mentioned. The client whose mother and uncle were diagnosed with the same condition. This is not genetics. There is not genetic factor for atrial fibrillation. It's an acquired condition, generally related with aging, and is not genetic influence. This is nonsense. The client who is out of work and has been experiencing increased stress is not the most usual. The psychological stress produces that. Or the client who had a myocardial infarction and required stent placements. I forgot to mention that clients recovering from catheterism, cardiac catheterism, and coronary artery bypass graft, the most common dysrhythmia that they present is atrial fibrillation or flutter, which is the same. So I think of these four, the one that is famous, that can suffer of atrial fibrillation is after cardiac catheterism. So it's not the myocardial infarction, no, is the stent placement that requires cardiac catheterization, yes? Or the client that have a CABG, coronary artery bypass graft. Those two procedures frequently complicate with acute onset of atrial fibrillation that need to be reverted back to normal because it's something transient with chemical or electrical cardioversion. Let's see what they're saying. Yeah, they agree. A history of recent myocardial infarction or cardiac surgery, in cardiac surgery, el CABG, no, increase the risk of developing an atrial flutter. Stress is not. Yes, stress can produce, okay, sinus tachycardia. The hypertrophic cardiomyopathy, the one that I told you can affect the atlas, is the one that have a strong genetic predisposition. And gastrointestinal viral illness, they don't say that it's viral, okay? Viral illness increase the risk of developing pericarditis. Yes, the most common cause of pericarditis is viral, okay? Okay, it is coincident. This one. A nurse is teaching a client who has arrhythmogenic cardiomyopathy about the risk of sudden cardiac death. Yes. This cardiomyopathy can produce ventricular fibrillation and sudden death. Which of the following clients statement indicates to the nurse an understanding of the teaching? A nurse is teaching, ¿qué es esto? A nurse is teaching a client who has arrhythmogenic cardiomyopathy about the risk of which of the following client statement is the same question. I will probably become easily constipated. No, nothing to do constipation and sudden death. I should ask my son to drive me to the grocery store. Question mark here. I assume that is if I am at risk of sudden death, I don't want to die while driving and kill other people. Maybe. It sounds very weird, no? Okay. And aware that I may develop frequent hiccups. Hiccups have nothing to do with, and the A, I don't know what is A. Because A is the same as this. Sorry, this is the practice question bank of ATI. So it looks like also a typo here. Let's see. I don't know what to answer because I need to know what is A. What is the first? Let's see. Okay, as I suppose the right answer was hidden here because they repeated the question instead of giving the answer. What was the answer? Clients who have arrhythmogenic cardiomyopathy should refrain from competitive recreational sports. Okay. They committed a mistake, and here they should say, I will refrain from practicing competitive sports. Okay, and this is the right answer because I told you those people that suffer the arrhythmias and sudden death because of hypertrophic cardiomyopathy have contraindication of practicing a sport because can die like practicing sport. So clients who have arrhythmogenic cardiomyopathy should refrain from competitive recreational sport as this increase the risk of sudden cardiac death. So yes, if I see this, I select this. The problem is that they hide this option under repeating the same question. A mistake of that. Those banks have a lot of mistakes. But we agree, and we mentioned that before, and that's why those athletes that didn't know they had this arrhythmogenic cardiomyopathy suffered this sudden death. Okay, they say cardiomyopathy should not affect a client's ability to operate a motor vehicle. Nevertheless, the same way that we recommend people that suffer of epilepsy, if we know that a person, as stated here, that is at the risk of sudden cardiac death, I think that in consideration of the rest of the possible people that are going to be in the middle of the way when they suffer a cardiac sudden death while driving, should be restricted from driving. I don't know if you agree with me, but thinking beyond the limitation of the person who wrote this question, whoever wrote this question, these people also should limit, okay, um, driving. No? So in some way, it is also correct. But what is specifically related with the sudden death is sports should avoid sports, but it shouldn't be here. It is also recommended that avoid operating motor vehicles if they suffer of increased risk of sudden cardiac death. And I hope you agree with me. And you don't want to be crossing the street in the moment that this person suffers a sudden cardiac death while driving his car. Okay. I don't know if you're listening me. I don't know if you're connected, but I never get okay feedback from you, but it's okay. I just do my best. Okay. Okay. And nurse teaching a peripheral venous. Okay. 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 Let's see this peripheral venous disease. Um, I will keep my legs in a dependent position. No, you keep the legs in dependent position. You have arterial disease, this venous disease. I will decrease my activity to prevent added stress on my legs. Don't we don't recommend decreased activity if you have varicose veins, because then you can develop DVT. People with venous problems, people with varicose vein should not decrease, should not rest, okay, should not keep the legs, immobile, steady, because they have risk of DVT. So I don't agree with this option. I will inspect my legs every day for changes in color, size, and temperature. Okay, because they could develop phlebitis, they could develop DVT, that could produce changes in the size of one leg, increased temperature, and even change in color. I like this. Let's see the last. I will need to massage. No, don't massage. Massage produce irritation or inflammation in the veins and can produce phlebitis. Massaging the veins are not good. No, I disagree. Using compressive stocking while standing while working is okay, but no massage. No massage. Massage is not good. So let me choose this. Okay, as you expected, it is the best. In teaching the client about managing the pericarditis with the following claims, time indicate to the nurse understand the teaching. Let's see, what is this? A nurse is teaching a client about the management of pericarditis. Hmm. Pericarditis depends. It is just pericarditis and there is pain and inflammation, it's treated with Advil, with ibuprofen. Ibuprofen is excellent for the acute pericarditis, especially the viral pericarditis. If there is pericardial effusion, needs pericardiocentesis. Let's see. Which of the following client statement indicate to the nurse and understanding of the teaching? I will contact my healthcare provider if I develop chest pain. Well, pericarditis is chest pain. I should refrain from sexual activity while taking the colchicine. Okay, colchicine. Colchicine is an anti-inflammatory medication that we are used to know in acute gout arthritis, in the podagra, this inflammation in the base, the grade 2. Yes, can be used in other different inflammatory process. One of them could be pericarditis. Okay, could be pericarditis. Colchicine is possible to be used in other inflammatory conditions. I don't see why it need to be restrained from sexual activity. I don't see why. Okay, you need to have care with sexual activity in acute myocardial infarction. Okay, is restricted until doctors give the green light. But in pericarditis, taking colchicine, which is for the inflammation, as I said, the acute pericarditis that is not having the cardiac tamponade is a benign condition that is treated with ibuprofen. I can assure you because I remember many cases that I in my experience. Let's see the other. I should avoid driving due to my implanted defibrillator. No, they don't have defibrillator implanted when have pericarditis. Rule out this. I will need to increase my fluid to 3 liters per day. There is no need of increasing fluids in pericarditis. There is no indication to increase fluids in pericarditis, the normal amount of fluid. Okay, I rule out this, and okay. Makes sense that contact the health provider if I develop chest pain, makes sense. So it's not the most, by ruling out the others, I say that, okay. This is the one that they wanted us to answer. Remember that sometimes in tests, especially school tests, you need to use some strategies to find the answer that they want us to answer to obtain a scoring, to obtain the point. Okay, here there is not too much. Okay, the chest pain is expected in pericarditis. But of course, doctors need to know if you have chest pain and should be should be informed to the doctor. So there is nothing wrong in this. What is not logical is that having this no cardiac tamponade. So I think that I explained to you very well the difference between acute pericarditis, which is a benign condition that produces pericardial rub, chest pain that alleviates with the leaning forward position, even can produce fever, okay? Elevation of the erythrosedimentation rate of the C-reactive protein, even can produce leukocytosis, but it's a benign condition that, as I said before, is treated basically with ibuprofen. Ibuprofen is the most commonly used, also indomethacin, but also colchicine can be used, okay? In this condition, there is not need of restraining from sexual activity, and there is not implanted defibrillator, so I rule out this. And there is not a reason to increase fluid. It's not really with dehydration or fluid volume deficit, by the contrary. So you rule out this because nonsense. So the most logical is to answer that. Yes, you need to learn how to develop strategies to dealing with your test. It's part of the survival in the nursing school and in life in general. Okay. A nurse is assessing a client. No, déjame abrirla. A nurse is assessing a client who has peripheral artery disease. We know what it is. For potential safety concerns. Safety. Safety. Which of the following client's statements should the nurse report to the provider? I don't go out much because of the pain in my legs. It's not desired, but it's safe. They are asking for safety concerns. I need to obey. Okay, this is one of the most common arguments with my students when I prepare students for English, is that they need to obey the questions. I am obeying the question. I'm talking about safety, not going out much because the pain in the legs is not good, but it's safe. I don't see safety issue here. I need to walk slowly as I lose my balance often. Okay, losing the balance is a safety issue because if you lose your balance, you fall. So it is possible. Third, it makes me sad. Psychological needs that I can keep up. I can't. I can't keep up with my grandchildren. You cannot keep up with your grandchildren. It is safe. It's not desired, but it is safe. I have a small healed area on my spine. Spine has nothing to do with arterial, peripheral arterial disease. Spine is the vertebral column. Small healed is already healed in my spine that is painful. I don't know what it is, but this has nothing to do with peripheral arterial disease and is not a safety issue. So which one we choose? The one that say that because the bad circulation, they have a balance impairment. For me, it doesn't make too much sense because in reality, what produces loss of balance is not the arterial disease, is the peripheral nerve. Nerve is different from artery. Peripheral nerve disease or peripheral neuropathy. The problem is that frequently people that have arterial disease also have peripheral nerve disease or peripheral neuropathy, especially diabetic clients. It is a comment, it's a personal comment, but they are asking, this is a strategy also, guys. They are asking about safety concerns. It is a command that I need to obey. I need to look here what is affecting safety. No, no, it's correct. I need to walk slowly as I lose my balance. Correct. Clients with peripheral arterial disease may have both decreased walking endurance and decreased balance due to the ischemia that occurs when walking. I don't agree with that. It is an statement I don't agree. But by strategies, I need to choose this because it's the only safety. The one that produces balance problems is the neuropathy, the proprioception of the neuropathy. But it is an interpretation, and we need to survive. I'm teaching you also how to survive in test because it's this class. It's not a content class. It's a class to prepare you for this. Okay. Okay. A nurse is assessing a client who has peripheral venous disease. Which of the following findings should the nurse recognize as a manifestation of peripheral venous disease? Okay. Diminished hair growth on the lower extremity. This is arterial. The decrease of blood flow, nutrition, and oxygenation will produce the follicles, the hair follicles of the legs to disappear. No, this is arterial. Shiny appearance of the lower extremity. The shiny skin is arterial. Loss of pigmentation of the skin area? No, it's increased pigmentation. Swelling and enlarged vein. What color is the white horse of Napoleon? Venous disease, swollen and enlarged veins. Veins. Yes, of course. What color is the white horse of Napoleon? It is a stupid question. You know that. Okay, but you want those questions in your test. You prefer those questions in your test. Hmm. It is similar to the other. Cause of atrial, a nurse is reviewing the lab result for a client who has atrial fibrillation. Which of the following blood test results should the nurse understand can be a possible cause of atrial fibrillation? So etiology, cause of atrial fibrillation. You remember that I mentioned several, no? Okay, elevated thyroid stimulating hormone. Okay, I don't know how good are you in endocrine, but the elevation of TSH, thyroid stimulating hormone, is hypo, not hyper. Is hypothyroidism. The one that you become fat, cold, lazy, you know, constipated. Huh? So this is hypothyroidism. Hypothyroidism is not the common cause of atrial fibrillation. It's hyper thyroidism. I mean, Graves' disease, the one that have, tachycardia, heat intolerance, anxiety, sweating, goiter, and popping out eyes. I mean, exophthalmos. No? So it is not. Elevated erythrocyte sedimentation rate. It is a test of inflammation. Atrial fibrillation doesn't relate with inflammation. Pericarditis relates with elevation of ESR, but not atrial fibrillation. Okay, it is the same. Oh, by strategies, B and C are the same because both ESR and CRP, both are tests for the same, for detection of inflammation, like pericarditis. If I have by strategies in a question two tests of inflammation, okay, in the same question, I rule out the option because it's the same. Elevated BNP. BNP is observed in heart failure. In heart failure. Hmm. So probably the best option here, even if it is not a, I didn't mention heart failure as a common cause of atrial fibrillation, but could be present both at the same time. So based in that in that is it is hypothyroidism because the elevation of thyroid stimulating hormone is hypothyroidism. You know, in hypothyroidism, you have low T3, low T4, but high TSH. While in hyperthyroidism, you have high T3, high T4, but low TSH. So no, these two are not, so need to be this. Let's see. Pues I'm incorrect. Elevated BNP levels will be an expected lab result for clients who have cardiomyopathy or congestive heart failure. This lab test indicates stretching of the ventricle from free overload, but doesn't. Okay. They say the correct is A. Elevation of TSH will be an expected lab test for clients who have atrial fibrillation or atrial flutter. Why? This lab result could indicate that atrial tissue excitability causes for hyperthyroidism. Okay, I'm so sorry. I apologize in the name of the person who wrote this question, but this person doesn't know anything about endocrine. Sorry for that, guys. Sometimes the question bank have mistakes. Sometimes the people that write that, don't know too much about all the medicine aspects, okay, of the diseases. And you know that it is a very medical test, okay, very medical, question bank, okay. Sorry, I apologize in the naming of this person. This person has not this idea of what is hyperthyroidism. TSH elevation is hypothyroidism, not hyperthyroidism. Please, if you have this question in the previous practice, etc., don't allow this question to misguide and confuse you. It is wrong. It is a mistake, okay? And it is okay. It doesn't mean that the question back is bad. Question back is excellent. We have been, at least in my opinion, a nice afternoon discussing a very good question bank. But from time to time, there is a mistake. And the role of the instructor is to detect the mistake and clarify the student so the question is not misguiding the student. Okay, so attention, hyperthyroidism, low TSH. Hypothyroidism, high TSH. The one that is associated with atrial fibrillation is hyper. This is correct, but elevation of the TSH is hypo, not hyper. So that's why we shouldn't choose this. Okay, so clarified. Okay. Okay, guys, this is what we have for you today. Any question? No? Are you awake? No? Are you too bored? Okay, good night then. Let me check the attendance.
Thank you, Professor. It was so good.
Thank you,
Okay.
Professor.
Okay, thank you for your feedback. Bye-bye.
Thank you, Professor.